Good afternoon, everyone, and thank you for spending this afternoon with us today. My name is Marina Ruzimovsky, and I'm a nurse practitioner at the Smith Institute for Urology. Today, I will be speaking about the expanding role of intravesical therapy and what we have learned over the past 40 years. According to the AUA guidelines for treatment of interstitial cystitis bladder pain syndrome, intravesical therapy is the second line of treatment along with physical therapy, oral agents, and pain management. Conservative therapies should always be tried first. Oral agents should be started at the lowest doses. Intravesical agents can be used in conjunction with oral agents and other forms of treatment. However, for patients who exhibit adverse effects to oral agents, bladder installations can be used alone. Intravesical installations can be both diagnostic and therapeutic. For patient presenting with pelvic pain, a bladder installation that relieves pain will point to bladder allergen. Cystoscopy will reveal presence or absence of Hanner lesions. Hanner lesions are relatively uncommon and represent only 5 to 20% of interstitial cystitis population. Most of interstitial cystitis patients simply experience pain with bladder feeling, as well as many other symptoms with absence of visible changes of bladder lining. Bladder installations can be beneficial for both groups of patients and can be used for different scenarios. Cystoscopy and endoscopic injections or fulguration of Hanner lesions can be beneficial for some patients and can only be achieved if there are focal lesions instead of diffusely inflamed bladder wall. A sequence of bladder installations with addition of antibiotic and steroid can aid in reduction of diffused inflammation and hopefully achieve a desirable effect for patients seeking surgical intervention. Those patients who do not benefit from bladder installations and oral agents for treatment of interstitial cystitis could have pelvic pain of other origin. These are some of the recipes of bladder installations. The installations on the left is the most popular in our practice. The therapy is off-label, but can be utilized for patients with sensitivities to oral medications. Studies of individual ingredients instilled into the bladder do not show systemic absorption and can be used in conjunction with oral treatments. The treatment is initially administered weekly and vary in frequency based on patient symptoms. For Hanner lesion patients, increased dose of steroid might be useful. Combination of 2% lidocaine and bupivacaine increases the duration of pain relief. Dwell time of an installation is 60 to 90 minutes. For some patients, alkalinized lidocaine installations are more effective than lidocaine sensorcaine installations. The combination of 4% lidocaine with sodium bicarbonate increases the absorption of lidocaine and can cause systemic side effects such as palpitations and perioral numbness. These side effects arise within minutes of completion of installation and resolve within 30 to 45 minutes. The patients receiving this installation for the first time should be observed in the office for 30 to 45 minutes. If reaction occurs, the installation must be drained from the bladder and the bladder must be irrigated with sterile water. These are known effects of some medications used for intravesical therapy. Lidocaine causes anesthetic effect. Heparin enhances the gag layer that lines the bladder. Steroids cause anti-inflammatory effect, and pentosan polysulfate reduces permeability of the bladder mucosa to toxic urine components. Dimethyl sulfoxide, DMSO, remains the only FDA-approved intravesical agent. It's an anti-inflammatory agent that directly targets the urothelium. It seems to have some analgesic and muscle relaxant properties. Some literature supports that DMSO combined with some other agents is more effective than DMSO intravesically by itself. This is our usual recipe. The common adverse effects of an installation are garlic odor for a few hours after an installation, worsening of symptoms for 24 hours. Full effect of therapy is not seen for 3 to 4 weeks. Call the office if symptoms get worse, as interstitial cystitis patients can get a urinary tract infection. Since some ingredients of anesthetic cocktail contain longer-acting pain relief agents such as sensorcaine, it is recommended not to hold an installation in the bladder for longer than 60 to 90 minutes to avoid urinary retention. Alkalinized lidocaine installation may cause adverse effects that I mentioned earlier, and therefore it's important to keep the volume of an installation low at the beginning, as well as starting with a lower strength of lidocaine, 2% instead of 4%. Some patients can achieve a desirable pain relief with 2% alkalinized lidocaine therapy and might not require higher concentration of lidocaine. For patients with Hunner lesions, addition of steroid triamcinolone might be helpful in order to reduce inflammation. Non-Hunner lesion patients can do installations without steroids. For many patients, one type of bladder installation might not work. There are other installations that can be tried. It takes time to tailor an individual type of an installation for each patient. Occasionally, after doing a course of one type of an installation, the patient stops responding, and this would be another reason to move on to a different installation. The pain that occurs immediately after or few hours after an installation, I call it rebound pain. As we all know, many interstitial cystitis patients have other conditions that might contribute to pain, such as pelvic floor dysfunction and vulvodynia. These patients may experience more pain immediately after or few hours after an installation. It is important to incorporate heat or cold, muscle relaxants, physical therapy stretches, and other medications to improve the discomfort. For different patients, rebound effect of an installation might be lasting for hours, and it's not unreasonable to consider use of bladder analgesics. In cases of diffuse bladder inflammation, one might consider doing 2 installations per week for the short time to improve pain control and inflammation in the bladder. As many of us know, the treatment of interstitial cystitis bladder pain syndrome is multifactorial and involves many disciplines. However, if therapies do not work, it is reasonable to reevaluate the strategy. Interstitial cystitis patients have many overlapping conditions that require equal attention, and only after a correct diagnosis, the plan of treatment can be established, which might also include agents for treatment of concomitant conditions with muscle relaxants, physical therapy, and topical agents. Interstitial cystitis has negative effect on quality of life, psychosocial well-being, personal relationships, and general health. Interstitial cystitis patients experience more pain sleep deprivation, and sexual dysfunction. Bladder therapy can be integral for reduction of symptoms and can be used by patients as weekly therapy or rescue treatments. Patients can learn to do installations in the comfort of their home. Learning how to do bladder installations can be done under the supervision of healthcare professional and after establishing the correct recipe for the patient. The patient must learn how to perform a technique of clean intermittent catheterization, mixing correct ingredients of an installation, and self-administration of an installation. It is up to each patient and their healthcare provider to create a schedule of installations and follow-up appointments. For patients who experience urethral pain, as well as pain in the bladder, the installation can be done retrograde first by pushing an installation into the urethra with a small syringe. With time, by desensitizing the urethra, it is possible to move on to a full installation into the bladder or simply use urethral therapy. In many instances, doing self-installations can be empowering for the patients, especially if they reside far from the practice. One's work schedule can't interfere with trying to be in your doctor's office once a week. Another group of patients would like to do a rescue installation during flare of symptoms. Moreover, one can do an installation prior to being intimate with their partner in order to reduce symptoms. Just one more thing. Some ingredients of an installation might not be covered by your insurance, which might be costly. However, if you calculate the cost of taking time from work, your family, and the fact that you must be attached to your physician's office for every installation, the price might be worth it. As I said prior, same installation might not work for two different patients. Therefore, it is important to establish which cocktail works first. Being able to do an installation in comfort of your own home is empowering. It also allows time with your family and participation of family members if needed. If possible, bring someone with you for your teaching session. Support is always helpful. It is often takes more than just a bladder installation to control patients' symptoms. Therefore, a multidisciplinary approach to treatment of interstitial cystitis remains to be a key to successful care of patients. Thank you very much.